Welcome to Trying to Conceive with Dr. Sasha Hakman, where we break down the science of fertility, share real patient stories, and explore the latest innovations in reproductive medicine. My name is Dr. Sasha Hakman, and I'm a double board certified OBGYN and reproductive endocrinologist and infertility specialist. I practice at HRC Fertility in Beverly Hills, but this podcast is an independent project created and hosted by me separate from my clinical work. Don't forget to subscribe so you never miss an episode. And if you want exclusive updates and resources, be sure to sign up for my newsletter. Just click the link in the episode description. Welcome to Trying to Conceive with Dr. Sasha Hakman. This is another solo episode, and today we're going to be talking all about unexplained infertility, one of the most frustrating diagnoses that a couple can ever get. I'm going to explain what unexplained infertility is, how you know if you fall into that category, what are the treatment options, and what are the success or outcomes of these different treatment options, their pros and cons, everything you need to know about it. So let's start by a basic definition of infertility. So infertility is defined as the inability to achieve a pregnancy after 12 months of unprotected sex if you're under the age of 35, or 6 months if you're 35 and up. So if you have been trying for that amount of time and everything seems good, you've been tracking your ovulation, you're timing sex accordingly, you've done all your research, you're taking your prenatals, you're even taking supplements for egg and sperm quality, everything seems to be lining up perfectly, but pregnancy has not happened. You might be falling into this category of unexplained infertility. So now you've finally decided, okay, everything feels fine, but we're going to go talk with a fertility specialist and see what's going on. Or you might even say, I'm going to go talk to my gynecologist and get preliminary testing to see what's going on, because it's honestly very appropriate to even start off with your OBGYN to get that initial testing, particularly if they are well-versed in it and they feel comfortable doing that. So what does that initial testing include? So the initial testing will actually look at the basic things you need to create a baby. Proof of ovulation. So do you have eggs and are you releasing the eggs? Female anatomy. And so one of the biggest things is evaluating the fallopian tubes. The best initial way to evaluate the tubes is through a test called an HSG, or hysterosalpingogram. And this is essentially placing contrast into the uterus and the fallopian tubes under fluoroscopy, which is a type of X-ray, and you get the outline of the fallopian tubes and you see if the dye spills out of the tubes to confirm that they are patent or they're open and not blocked. The reason this is so important to investigate is because fertilization happens inside the fallopian tube. That's where it all takes place, where egg and sperm meet. So if there's any blockage in the tubes, then pregnancy can't happen on its own without assistance. So the other thing to look at is the cavity of the uterus. And so an HSG can also sort of help outline the uterine cavity to make sure it's got a normal shape, but it can sometimes miss things inside the cavity that may make conception a little bit more difficult. And this is where further evaluation with a saline sonogram can be helpful to detect what's going on inside the cavity. Are there massive fibroids? Is there a polyp in there? Although usually traditional ultrasound can detect anything that's really major that can impact fertility. And then finally, looking at the sperm, a semen analysis to see if there is enough moving sperm. What is the concentration and what is the motility? So let's just say everything comes back normal in this preliminary testing. Then you fall into the category of unexplained infertility. But something that a lot of couples don't realize is if you have one blocked fallopian tube, you still may be in the category of unexplained because you really only need one open fallopian tube for fertilization to take place. And that tube can actually pick up the egg on either side. Everyone thinks that the tubes are sort of sticking out to the side and the ovaries are directly underneath each fallopian tube. But what's really happening is they're all sort of squished behind the uterus inside the pelvis right over your rectum. So that's typically how it's all laying there. So the fallopian tubes are so close to each other, same with both ovaries, that one tube can pick up an egg on either side. If one tube is open, you have a normal present uterine cavity, you are ovulating in a regular, predictable manner, and there's enough sperm, it doesn't even have to be a perfect semen analysis. If the morphology, for example, is slightly off, you still fall into that category of unexplained, because if there's enough moving sperm, by this time, pregnancy should have happened. The reason we use that 12-month definition is because usually by 6 months, 80% of couples will have conceived. And so if it hasn't happened, usually that indicates that there's something going on. And when we do that preliminary infertility evaluation, unexplained infertility is diagnosed in about 15 to 20% of infertility cases, sometimes up to 30% based on the study that we're quoting. So unexplained infertility happens a lot. And the biggest misconception with unexplained infertility is that there's nothing wrong and I'm not getting pregnant. Unexplained infertility does not indicate that there's nothing wrong. It just means that all preliminary testing was not able to identify what the issue was. So as a result of that, our treatment for unexplained infertility is empiric. And there's really two main treatment options. And this has been studied so much. There are so many high quality randomized control trials that have influenced how we manage unexplained infertility. So if we go in order of what the first line treatment is versus second line, first line treatment is a combination of ovulation medications plus intrauterine insemination. Oftentimes, I will get patients after they've been getting treatment cycles elsewhere where they are receiving either only IUI with a natural cycle, or they're receiving an ovulation drug and they're doing it with timed intercourse. So let's talk about what the data says about that. Starting with the ovulation drugs. So a bunch of RCTs have compared doing ovulation induction versus expectant management, which is essentially doing nothing. And they found that the pregnancy rates are the same. What is the pregnancy rate with unexplained infertility if you are doing nothing? It's 2 to 4% per cycle. So it's very low. Doesn't mean it's impossible. It just means it's very low. Now, if I give you a medication like Clomid or Femara, which is letrozole, to help induce ovulation, which you're already ovulating, I'm not doing anything different than what's already happening. You're releasing an egg. So I'm not actually improving your odds at a pregnancy, even if there's multiple follicles that are being recruited with these drugs. And so you got to keep in mind, you're not really increasing the chance at a pregnancy, but if a pregnancy were to occur, you are slightly increasing the chance of multiple gestation, most commonly twins. And while that sounds really enticing, you've been waiting a long time, you really want a baby, the idea of having 2-for-1 pregnancy sounds really exciting, but twin pregnancies are not without risk. Now, most twin pregnancies will do well. However, there is an increased risk to mom and baby throughout the pregnancy and at the time of delivery. And some of our biggest concerns is preterm birth leading to NICU stays. And the worst is if preterm delivery occurs before viability. That's a really, really tragic outcome. So obviously, as fertility specialists, we feel obligated to maximize the safety of your pregnancy and the likelihood of you walking home with a baby. So ultimately, doing ovulation induction medications alone is it's not been shown to be beneficial. What about doing IUI alone? Doing IUI alone compared to natural conception or expectant management, which is just having timed sex at home, it's the exact same thing once again. It's a 2 to 4% chance of success per month. So you're really not doing anything except for costing you money and time. IUIs are not necessarily inexpensive, especially if you're paying out of pocket. And so you're going to be paying at least over $1,000, sometimes a couple grand per month for the exact same odds at a pregnancy as having sex at home. So really no advantage there. What the studies have shown repeatedly is where you're really starting to increase your odds at a pregnancy is when you combine the ovulation drugs with insemination. And so how this works is most commonly we give the pills. It could either be Clomid or letrozole. And what these pills are doing is they're essentially helping your brain to increase the amount of FSH, or follicle stimulating hormone, that's being secreted. And this is a messenger hormone from the brain that tells the ovary to start recruiting follicles and grow those follicles. So in this case, with Clomid and letrozole, you may be recruiting more than one follicle. So you're slightly increasing the chance of twins or multiple gestation. And it's important to have that conversation if you're doing this treatment modality with your doctor about how you feel about twins. Because while we're trying to avoid twins, it's certainly still a risk. And if having twins is something you absolutely do not want to risk, then it's really important to have that discussion with your doctor. Because while you are increasing the odds of a pregnancy, if there's multiple follicles being recruited, you are also increasing your chance of twins. If we're talking specific numbers, that increased odd is about 5 to 8% with Clomid, slightly higher with letrozole. And according to one of the biggest clinical trials that we often quote, they showed that with letrozole, there's about a 13% risk of twins. Now, something to keep in mind that letrozole is actually used off-label. It's not FDA approved for ovulation induction, but it has been shown to be really safe. And there's no concern for birth defects when you're giving letrozole to induce ovulation. We've been doing it for years, and there appears to be a little bit of superiority to Clomid. The biggest reason I love letrozole over Clomid is that in some women, Clomid will actually thin the lining of your uterus, decreasing the chance of implantation. But with letrozole, it does not do that. And that's because letrozole doesn't affect the lining, but Clomid does. Now, what about injectable medications to help recruit more follicles? These are called gonadotropins. And while gonadotropins will slightly increase the chance of pregnancy if you're using that with IUI compared to the oral pills, there's also a very, very high chance of having a multiple gestation, such as twins, but possibly even more than twins, like triplets. And those are really scary scenarios when you have triplets or even quads, because a lot of the time it does not end well. Remember, we're aiming for you to be safe and to walk home with a baby. If you end up with twins, I don't freak out when I see twins. I do freak out when I see more than twins, that's for sure. So gonadotropins only slightly increases the chance of pregnancy per month by maybe up to 2% in a given month. However, it significantly increases the chance of multiple gestation, and the textbooks have quoted about a 32% chance of multiple gestation if you're using gonadotropins. Now, there was a study that was published by a friend of mine, and it is an incredible study, and I'm going to include it in the description of this episode so that you can refer back to it. But basically, it was looking at what are the chances of multiple gestation based on the number of follicles that are available at the time of trigger, based on age, right? Because if you're 25, for instance, and you have 5 follicles at the time of trigger, no way. Huge risk. I would cancel that patient. I wouldn't even toy with that idea. But if you're 45, this is a whole different discussion. Yes, there's a slight increased risk of multiple gestation, but that risk is relatively low, around 1%. But you are significantly increasing the chance that that woman will actually get pregnant. So that was a very important study to do, and I refer to it all the time for my patients to discuss their specific risk of multiples and chance of pregnancy based on the number of follicles that they have. So I'd really check out that study. It's a really good one. So once again, to recap, you always want ovulation meds with insemination. On average, it'll give you about a 9 to 10% chance at a pregnancy in a given month. That's really where the success of it lies for unexplained infertility. Gonadotropins, which is the injectable medications to help you ovulate, will give you a slightly higher chance, however, much higher chance of twins, depending on female age. So there are circumstances where we absolutely do it to increase the chance at a pregnancy, particularly for women who are above the age of 40. If you're trying to conceive, the supplements you take now really matter, especially when it comes to supporting your fertility from the inside out. As a double board certified OBGYN and reproductive specialist, I'm often asked what I personally recommend to patients preparing for pregnancy. My go-to is Bird & Bee's Female Fertility Power Prenatal plus CoQ10 pack. It's a preconception powerhouse, combining your prenatal, DHA, and powerful antioxidants into one easy daily pack. So no more juggling bottles. Here's what sets it apart, is the clinical grade support for egg quality. You get 600 milligrams of CoQ10, shown in studies to significantly improve IVF outcomes and boost ovulation for those with PCOS. It also includes NAC, which helps reduce oxidative stress. And unlike most prenatals, it doesn't skip essentials like folic acid, the only form still recommended by the American Society of Reproductive Medicine, methylated folate, choline, preformed vitamin A, nutrients that play critical roles in fetal development and egg health. Plus, you're getting iron to improve blood count and vitamin E for improved blood flow. It's vegan, gluten-free, third-party tested, plus tested for heavy metals. It's also formulated by fertility doctors and naturopaths, so I know my patients are getting the support they need with none of the unnecessary fillers. Want to try Female Fertility Power Prenatal for yourself? Head to birdandbee.com/Sasha Hakman MD and use the code TTC Podcast at checkout to get 10% off your first order. That's TTC Podcast for 10% off, because your fertility deserves clinically backed support. Now, aside from ovulation induction or ovarian stimulation with insemination, there's alternatively IVF. So those are really your two treatment options. And if you haven't already listened to my episode on the basics of IVF, I highly recommend that you listen to that first so that you really understand what I'm talking about here in terms of really just going more in depth in the detail of understanding what IVF entails and the success rates of IVF. So outside of IUI, you may be moving on to IVF either initially or after multiple failed IUIs and ovulation induction cycles. Now, with IVF, the advantage of doing IVF is that the success rates are significantly higher, depending on female age, of course, because female age is the number one predictor of reproductive success. So as women age, the success of IVF will go down, of course, but it's still much higher than IUI. The advantage of doing IVF is that it's both diagnostic and therapeutic. So when you go to do IVF, we may be able to see under the microscope, okay, egg quality actually doesn't really look very good. Or when we go to fertilize the eggs, the fertilization rate was really low. So there's something happening there. Or between fertilization and embryo development, things just stop. The development stops, the cells stop replicating, and most will degenerate and die. And so we start to understand in what phase of development things are going wrong. And it may be able to help us to sort of fix it in the lab through different IVF add-ons. But let's say you have unexplained infertility and you do IVF and the first IVF cycle has failed. What makes it really tricky is that usually it is more likely to be unsuccessful again, and you might be down this road of having to do multiple IVF cycles, typically because there's some sort of major egg quality or sperm quality issue that just isn't being seen or is not detectable from initial evaluation or even after an egg retrieval. Now, ultimately, the IVF success rates are 40 to 60% per cycle, which is way higher than ovulation induction IUI cycles for unexplained infertility, that 9 to 10% range. So you're talking way higher odds. Obviously, depending on female age, the younger you are, the higher that success rate is. If you're under 35, you're probably closer to the 60%. But the question is, when do you jump to IVF? Is it right away? Is IUI a waste of time? Or do you really give IUI a good shot? And while this study is very old, it's still highly quoted and it was very well done. There was a clinical trial out of Massachusetts called the FAST trial, where they looked to see after 3 versus 6 IUIs, what is the cost effectiveness of doing up to 6 IUIs before you move on to IVF? And what they found is that after 3 IUIs, it was much more cost effective to move straight to IVF after 3 failed IUIs, because after 3, the likelihood of the IUI cycles really went down, but the cost significantly increased and there was also delayed time. So what you're doing is you're spending up to 3 more cycles paying for IUIs, spending this time hoping and being crushed every time it doesn't work, to then end up having to move on to IVF. When a lot of that expense, especially if you don't have insurance coverage, could have been put towards your IVF cycle in the first place, and probably time to baby would have been diminished. The advantage of doing IVF right away is, number one, the possibility of having multiple embryos for subsequent siblings. So if you are somebody where going through treatment cycle after treatment cycle has felt somewhat traumatic and emotionally very burdensome for you, and you don't really care to try to have more conservative approaches to treatment, then jumping straight to IVF might be a better option for you because the success rates are higher. And if it is successful the first time around, you are also more likely to have additional embryos for more kids down the line without having to think of the impact of age after you're ready for baby number 2 and or even 3. And then also having to go through trying and disappointment and trying and disappointment. That's not to say that just because you have unexplained infertility and you need a treatment for baby number 1, you will certainly need treatment again. Infertility is not always this permanent thing. It is totally possible, like in my case, to need IVF for baby number 1 and then get pregnant spontaneously on your own the next time. My theory behind this is because although unexplained infertility means that there is something wrong, but we weren't able to necessarily identify it, newer studies are actually showing that in almost half of unexplained infertility cases, well, specifically 44%, these women have a previously undiagnosed endometriosis. So it was never detected up until now. And the studies that looked into this, they waited for those who had a failed IVF cycle for unexplained infertility, did a laparoscopy. So this is where you go in with a camera into the abdominal cavity, take a tissue biopsy, and this is where you find endometrial-like glands. So it's tissue similar to the lining of the uterus present outside of the uterus. This is a highly inflammatory condition. There is an immune component to it as well, which can affect not only your anatomy, so it could affect tube function. Even if the HSG came back normal, it can affect egg quality, it can affect implantation, and increase the risk of pregnancy loss. So endometriosis is particularly tricky because it affects so many different aspects of reproduction. And the fact that it was present in 44% of cases, and mind you, most of them, almost 75% of these endometriosis diagnoses for unexplained infertility were mild. So in many cases, patients may not have any symptoms, or even when you go in laparoscopically, anatomy looks pretty good. You just see these tiny little spots that shouldn't really affect the patient too much. But when you do the biopsy, you see that it is present. But what's tricky about endometriosis is that the severity of it and the grading of endo doesn't necessarily correlate with pain and symptoms. So it could be really mild and you're dealing with a really tough case of infertility. And in many cases, it could affect egg quality so much that while you went into your first IVF cycle thinking, this is going to work the first time. I'm young, I'm doing IVF, boom, we're going to have a baby after this cycle. And then to your shock, it didn't work. And now you're back to the drawing board. You're considering doing this again, maybe a second, maybe a third time. And that's really, really difficult. Now, there are probably a lot of other causes that we know and also don't know about when it comes to unexplained infertility. I have theories about genetic causes that are affecting the reproductive hormone receptors. And if the receptors are not working properly because of some sort of genetic mutation in them, then it's probably affecting the signaling and the ability of embryos to develop and to implant. Now, this is something that is massively understudied. And this is actually something I wanted to study when I was a fellow and do my thesis on. But of course, I just did not have enough funding for that kind of research. There's probably a genetic component. And I'm not talking something necessarily inherited from your family, because you might be coming from a family of very fertile people and you're the only one dealing with this infertility. So it could be what we call de novo mutations, a mutation that happened after you were already an embryo that was developing. It could be environmental factors. I talk a lot about environmental toxins, and if you haven't already checked out my episode on optimizing your natural fertility, I do go over environmental toxins and how to sort of optimize and reduce exposure to them to improve your fertility. But at the end of the day, depending on where you live, this can really affect your egg and sperm quality. If you live in a major city with a lot of air pollution, it's really hard to avoid that. If the water quality is suboptimal, this is where, trying to focus on filtering your air and your water as much as you can be helpful, but it doesn't necessarily reverse the exposures that you've already had that has affected your fertility now. So while it's unexplained and we may not necessarily know exactly what's going on with you, there's a lot of theories behind what it may be and what we can do to improve it. And of course, immunological factors, because the immune system plays a huge role in your reproductive tract and for pregnancy. So if there's anything off with your immune cells, then that can certainly affect it. And we just don't have all of the testing available right now. So in terms of how many IUIs you should be undergoing or when to jump to IVF, that's a really, really personal decision. The advantage of doing IUI cycles, and when I say IUI, I'm really referring to ovulation induction plus IUI, as I mentioned earlier on in this episode. When you're doing IUI cycles, the nice thing about it is it's less expensive, it's less involved, and there's still that ability to feel like, okay, this was somewhat of a natural pregnancy, very little medical intervention here. But the downside is that you might be revisiting this again a few years later for more children. And at that point, as you're getting older, it's less successful. The advantage of jumping straight to IVF is, typically speaking, success rates are so much higher. But of course, it's physically, emotionally, and financially a lot more demanding than doing IUI cycles. Now, I do also want to mention briefly one new technology that has come out, which is being advertised for unexplained infertility, and that is intratubal insemination. It's a special catheter that goes all the way into the fallopian tube so that you're bypassing the uterine cavity to deposit the sperm. And just to give a quick synopsis of how we deposit the sperm for IUI, this is where we place a catheter typically inside of the uterus after we have washed the sperm, and we inject it with a catheter. The idea behind intratubal insemination is that you're taking that washed sperm sample, depositing it directly in the tube where fertilization happens. But the problem with the validation study is that it has a small sample size, and while they say that their pregnancy rates are significantly higher than IUI rates, the traditional IUI rates that they're quoting is not necessarily reflective of the mass data for unexplained infertility. And so I'm not really sure that it's worth the extra expense to do intratubal, though I just think that more data is needed. We might end up finding that it is really, truly superior to traditional IUI. But this is something that's always worth discussing with your physician to see if it makes sense for you to pursue that or not. Ultimately, unexplained infertility is really a very frustrating place to be when you don't have a specific answer of something being wrong and correctable. Sometimes it's easier to process being told that your tubes are blocked, you need IVF. There's severe male factor infertility. This is the next step for treatment. Or you're not ovulating. We're going to need to give you medications to help you ovulate more predictably and regularly. Those are all things that have a solution. In this case, we're just sort of blindly treating based on your personal preference, whether it's IUI cycles or jumping straight to IVF, which, once again, a very personal decision. It is completely up to you how you want to start, unless, of course, there's specific scenarios where insurance, if you have insurance coverage, they might mandate that you have to do IUI cycles before you can jump to IVF. But generally speaking, it is up to the patient whether you want to do IUI for up to 6 cycles even, or longer than that, versus jumping to IVF after 1 IUI cycle. You sort of dictate your plan of care as long as you understand what your options are and the pros and cons to each. If you have any questions specific to unexplained infertility, I'd love if you drop your questions in the description and I will be sure to answer them.